All right, so this morning section is on contrast echo, and we're going to discuss the indications for contrast and the type of contrast. Of course, we have saline contrast, the so-called air bubbles, and we have micro bubbles. So those are two different type of contrast agents, and the indications for them are also different. All right, so the indications for contrast, and now we're talking about um, contrast in general, but we'll separate them out. So contrast in general, the indication, if you're looking for septal defects and shunts, then you would use mainly saline contrast, and we'll explain how you do that. So if you're looking for an atrioseptal defect, PFO, or a VSD, um, then you can use saline contrast, normal saline. For endocardial border detection, that is, if you do a study that is suboptimal and you want to increase the endocardial border so you can see whether it's contracting, yes, well, yes or no, then you do use your microbubbles, some microbubble contrast for endocardial border detection. To enhance your Doppler signal, you can use both saline or microbubbles. And then for myocardial perfusion, we use microbubbles. And you use a microbubble for myocardial perfusion is a little tricky. And then what we call persistent left superior vena cava detection, we use saline contrast for that. Again, we do two types of contrast study in echo. We do air bubbles and micro bubbles. With the air bubbles, we get normal saline and we agitate it. So in one syringe, you'll put about 10 mLs of normal saline. So you have a three-way stopcock and you connect two 10 cc's syringe to it. In one of the syringe, you're going to put normal saline, about 10 cc's, and then the other syringe you're going to put hair, just about 3 mLs of hair, and you agitate it between the two syringes to create bubbles, air bubbles. And then micro bubbles, there are 3 micro bubble that is on the market. The ones that the one that is most commonly used now is Definity. You also have Optison, and then there's another one. All right. So again, when you're doing ear bubbles, because if you're doing any type of exam, they want you to know, how to create the bubbles. So two 10 ml syringes connected via three-way stopcock. One is filled with normal saline, and the other syringe, you have about 2 to 3 mLs of hair. So we'll actually do a demonstration of this in due course. So the air and the saline is mixed together to produce agitated bubbles, to produce bubbles. So you're gonna, since you have a three-way stopcock, you're gonna mix the air and the saline. Okay, so you're gonna push the saline in the hair, and then you're gonna push the hair in the saline, and you're gonna do that uh, for a few minutes until you create your agitated the saline. All right. So again, what you're gonna do, your IV should be in the antecubital vein. So you're probably not gonna get a good study if you put the IV in the hand itself or in the forearm. So the IV should be in one of the large antecubital vein, and that's very important because a lot of time I go to do studies, the IVs in the patient's hand or forearm. So if you're going to do saline contrast study, the IV should be in the antecubital vein. And then you inject the bubbles very, very quickly. So you in the IV, so the 10 mLs of agitated saline you inject very, very quickly into the vein, and then the bubbles. Of course, veins travel to the right side of the heart, so the bubble is going to travel to the right side of the heart. It's going to opacify the right side of the heart, and that way, if there's a septal defect or a shunt, you can pick it up. So when we talk about atrial septal defect, a PFO or a VSD, all right. So if you see bubbles on the left side, then you have to have a defect or a shunt for that to occur. There's something we call a negative contrast, and a negative so you have to be careful when you use terms like this, because for a positive study you're going to have bubbles on the left side, and a negative study you're not going to get any bubbles, but you can have what we call a negative contrast. And what happens is, when you have, say for instance, you have an atrial septal defect, and the pressure in the left atrium is greater than the pressure in the right atrium, then when blood flows from the left atrium across the defect into the right atrium, it's going to create a void in the bubbles on the right side. And that is what we call a negative contrast. It's not a negative study, but it's a negative contrast, because it clears away the bubbles from the site of the defect. All right, so, and a very important point is that the ear bubbles that we use are fairly large, and they do not pass through the lungs, okay, which is different from the microbubbles. The microbubbles pass through the lungs, and that is why you see it in the left sided chambers relatively quickly. And so your microbubbles your saline contrast is gonna look like this. So when you give you see it opacify the right side of the heart. Okay, so you agitate your saline three-way stopcock, 10 mLs of saline in one, and 2 to 3 mLs of air, and you mix the air and the normal saline to get these not micro bubbles, to get the saline bubbles. And then antecubital vein, rapid injection of your saline. Okay, it's going to go to the right side of the heart, and you see it opacify the right atrium and the right ventricle, and you don't see any bubbles on the left side. Very important. If it's an atrial septal defect or a PFO or a VSD, you should see the bubble within the first 3 cycles, cardiac cycles. First 3 cardiac cycles. If it's longer than that, it's probably due to intrapulmonary shunting. Very important. Okay, it has to occur within the first 3 cardiac cycles. If it takes longer than that for you to see the bubbles, probably intrapulmonary. Okay, of course, when you see this, so this is a transesophageal echo right there. All right, so okay, so you inject it, and you want to see a nice opacification like this. This is a fairly decent opacification. All right, so that's all saline contrast. Agitate it, and you get that. So antecubital vein. All right. So we're going to move on now to microbubbles. So microbubbles are different from saline bubbles in that these microbubbles are created. You have different manufacturers. I say at present there are 3 that are approved for use in the United States, and the microbubbles, they have an outer shell which is made of lipid and or albumin. So Definity, you have a lipid outer shell, and Optison, it's an albumin outer shell. So you have an outer shell and then a gas core. So, you know, you have the outer shell, which is either lipid, this is Definity, albumin, which is the Optison, and then you have a gas core. And the gas that is used in both Optison and Definity is octafluoropropane. Octafluoropropane, that's a gas that is used in these two. And the size of these microbubbles, they're very tiny, 1 to 4 micrometers in diameter. So they're smaller than the red blood cells. So, of course, the red blood cell travel through all the circulation. So these microbubbles can travel through all the circulations as well. Okay? You get what we call a high degree of echogenicity, and that is the ability to reflect ultrasound wave. And these microbubbles, they follow the harmonic response, in particular the second harmonic frequency. All right. Okay. All right. So it's important to know. You have to know these properties of the microbubbles. All right. So the outer shell. So if someone come to the Echo Lab and you plan to use a microbubble and they give you a history of being allergic to eggs, you can't use the Optison or any other type of microbubble the outer shell is albumin. Because remember, eggs, they when someone is allergic to egg, they're allergic to the albumin component of the egg. So you can't use your Optison. The other one, which is Definity, it's a lipid outer core. And then the gas that's inside them is octafluoropropane. You have to note the size is 1 to 4 micrometers. All right. So another very important point is that these microbubbles, these bubbles, you can burst them if you increase the mechanical index on your echo machine too high. So when you look on your echo machine, you're gonna see MI, mechanical index, okay? So you can enhance the destruction of the bubbles, burst the bubbles, if your what we call your mechanical index is greater than 0.7. And the mechanical index is defined as the peak rarefaction pressure divided by the square root of the ultrasound frequency. Okay, we're going to go over this a little bit more. But it's the peak rarefaction pressure divided by the square root of the ultrasound frequency. And again, microbubbles cross the pulmonary capillaries. So that is why you inject it into a vein, and in a short order, you're going to see it on the left side. You're going to see it in the left side of the heart. It's not because there's a defect, it's because it travels through the pulmonary circuit, just like your red blood cells too. Um, so we commonly, when we do stress echo, we commonly use microbubbles because sometimes you cannot see the endocardial border. You cannot see the endocardial border of the LV. So if we give contrast, then you can see the endocardial border fairly clearly. Okay, so this is a stress echo where we use microbubbles. So you can see that the left ventricular cavity is opacified, and you can see the endocardial border fairly well. So this is what we're talking about. You have this outer shell, And again, the outer shell can be either albumin or lipid, and then the inner core is gas. This they actually doing some experiment using microbubbles to transport drugs, since to transport medication, um, especially certain type of cancer, because if you have a cancer that's located, say, in the brain, and you want to just target that area, then you can give put the drugs in the microbubble and then just transport it to that location. So there's studies going on with that. So again, when you pull it up, it sort of look milky. Like, you have the outer shell, the gas core. It varies from 1 to 4 micrometers in diameter, and this is an indication. So you do this study was performed. You can't see the endocardial borders; it's poorly defined. You give your microbubbles, and you get fairly decent endocardial delineation, so you can determine the ejection fraction and talk about wall motion abnormality. So, and then for this case, there's something in the apex. You're not sure if it's just trabeculation or whatever. If you give your microbubbles, then you can see that it's a mass. So the bubbles didn't go through this object, this mass. Okay, so this is probably a thrombus right there. Okay, as opposed to this case where you look, you see there may be something and give you contrast, and of course it opacify the whole LV cavity, so there's nothing there. So if there's a mass, you don't expect the microbubbles to go through the mass. Okay, so if you're looking for thrombus, clots, and you're not sure, the use of microbubbles can be um, very, very helpful. Again, this is a huge mass. It's a thrombus, a blood clot. Give you microbubbles, you can see it stops where you have the thrombus, and in this case, it was definitive. So that concludes the lecture